Hi, I'm Eric Hartman. I am the Director of Advocacy for the Choroideremia Research Foundation. And like Corey, I've been around since the beginning. And our journey, as your journey, definitely needs to involve getting tested genetically. So many of us have and probably still are. There's so many people living with an RP diagnosis that don't know they have the disease. My best example is I know of one family where the son was diagnosed with choroideremia, the mother was tested and confirmed choroideremia, and they had 48 living relatives that had RP diagnosis. I mean, so it's a huge thing. And I just came back from Retina International. I'll talk about that a bit tomorrow. But Retina International is doing a global task force that I've been involved with for the last year and a half. And it's all about making the ability to get a genetic test equitable and easy across the globe. And there are all kinds of challenges. But one of the things that we really need to think about, I'm sorry, the walls are, wow, I've moving walls. But it's incredibly important, and I'll talk about that tomorrow. But one of the things that is very important is to understand what it means to get an eye exam. And the foundation, have also been very involved on the legislative end with the rare disease community in promoting that genetic counseling, which is vitally important, be included with CMS and with insurance coverage. And that's something that is very important because you can learn a lot from the genetic counselors. The foundation itself has sponsored travel grants for genetic counselors to their conferences, and I've been both at the American Ocular Genetics group and at the UK eye genetics group there. So what I'd like to do is now introduce Jenina, I'm sorry, and your last name, I just lost it. Capasso, good grief, I feel so bad. She is the Ocular Genetics Program Director at the University of Rochester. Both of our panelists are from the University of Rochester, and we greatly appreciate them being able to share with you the importance of getting your genetic testing. And I do want to say that the Retina International is putting in a huge effort to change the term from genetic testing to genetic diagnosis. In fact, Retina International will no longer refer to it as genetic testing. It's genetic diagnosis. Thanks.
Thank you for the introduction. And our talk today is geared more towards families who might be going through this diagnostic process, and not so much for the clinicians or researchers in the room. All right, so we have 3 learning objectives for our talk today, and we'll hopefully leave some time for questions. So 3 questions that we want to answer for you. Why get genetic testing? And Eric spoke a little bit about that, and we'll tell you more. Who should be tested, or where do you start? And then how can I obtain genetic testing? First of all, what do we know about choroideremia? We know that it's a genetic eye condition, X-linked recessive inheritance, or as we learn more about this condition, it might be more appropriate to say that it's X-linked. And the symptoms that are usually reported by people who have this diagnosis are trouble with night vision or peripheral vision first. Usually central visual acuity remains pretty well preserved, at least in the early stages. Sometimes later in the progression, some people experience blurring of the central part. But when you hear that history in a clinic, it sounds exactly the same as another diagnosis, which we've talked and I've heard a lot of people mention before, which is retinitis pigmentosa. And for providers who are not familiar with these rare diseases of the eye, including choroideremia, RP is far more common, probably 1 in 4,000, maybe even 1 in 3,000 worldwide, whereas choroideremia is more like 1 in 50,000. So for somebody who's not familiar or have ever heard choroideremia, they might tell the patient they have retinitis pigmentosa. And so the question remains, is it retinitis pigmentosa or is it actually something else like choroideremia? Family history is actually a critical tool that's been around and used in genetic medicine longer than we even had genetic testing available, and has been very useful, at least in counseling families about certain inheritance patterns and the chance of it happening again in future children. And this is a typical X-linked pedigree. So this is kind of what we're looking for when we ask questions about family history in our genetics clinic. And what we're looking for, if we're expecting X-linked inheritance, usually we typically see males affected more frequently than females. These females are not reporting the circles. I should backtrack and say circles represent females, squares represent males, if no one's familiar with the family tree diagram that we use in our clinic. And the shading represents people who are reporting symptoms or we consider affected. And this individual right here, I don't know if you can see the arrow, is our patient, and they're maybe the ones reporting this family tree to us, but their mother isn't necessarily complaining of any visual symptoms, so we didn't consider her affected. Her mother's not affected, but her father is, and his mother is shaded gray because she is reporting symptoms, but she's much milder, or maybe her onset of symptoms was much later than the males in her family. The most critical thing we're looking for is that there's no what we call male-to-male transmission where a father passes it on to his son, because when a gene travels on the X chromosome, males cannot pass that on to their sons, because in order to have a male child, they pass their Y chromosome, not their X chromosome. So this would be extremely helpful in the clinic in guiding us towards X-linked genes to offer testing for. And in genetic retinal diseases, there aren't that many. So we kind of are able to narrow our hypothesis for a diagnosis pretty small, and maybe get the family to an answer quicker. But that's not always real life. Often in the clinic, the male that we're meeting with in our clinic who's getting the eye exam and considering genetic testing is the only known affected individual. There's no clues in the family history. When we're considering retinitis pigmentosa or maybe even choroideremia in an only male affected family member, we do still consider X-linked recessive conditions. So this might come to mind, and obviously the eye exam is also a very important piece in guiding how we select genetic testing. But genetic testing is much more important in this family or this individual to confirm the diagnosis, because there's less clues in the family tree. Okay, so that brings me to why have genetic testing. And there are two major reasons, but a couple of things that fall under both of those reasons. One, you want to confirm a diagnosis. Usually when we meet with people in our clinic, they have a lot of questions. They want to know, what do I have? And if you're telling me this is something that doesn't have a standard treatment to intervene with my vision symptoms right now, what can I expect over time? So prognostically, what is this going to look like in 10, 15, 20 years? And usually if we have an accurate gene diagnosis, then we can counsel a person a little more specifically about the type of symptoms, the type of progression of their diagnosis. Also, if we have a gene diagnosis, that gives us a better understanding of what the underlying mechanism of disease is. So it tells us a little more about how did the eye get sick and what led the eye to have the vision symptoms a person's experiencing. And if we understand that disease mechanism, that's going to lead to a better approach to that person's treatment, or identifying the best targets for that person's treatment. And then research participation. So like I said, if this is there's no standard approved treatment available for this diagnosis, people often want to research, understand what research is ongoing out there, maybe participate in it, maybe fundraise for it. But before you put in a lot of time, effort, maybe some money into research. You want to make sure that you are investing in research that's related to the diagnosis in your family. And something that I forgot to put on this slide, but is also equally important for all of these things, if you know the gene diagnosis or have an exact diagnosis, especially if you have a family like this, you're receiving a rare diagnosis that you may never have heard of. You absolutely have no idea, is there any other person in the world that has this or experiencing the same symptoms? And so you might want to network or meet other individuals and connect with them, somebody who has a basic understanding of what you're going through, and that can be incredibly valuable. And then, of course, recurrence risk is another thing that people have questions about. So if this is genetic, how is it running through my family? Are there other family members at risk for having vision symptoms? Are my children at risk? Or could I have future children with this? And even today, in today's world, if you have a gene diagnosis, there are a lot of reproductive options for families to explore if they feel very strongly about not passing on a certain genetic variant. So that brings me to, who do you test? Well, in a family who doesn't have a gene diagnosis yet, if no one's had genetic testing, the most appropriate person to start testing in is a symptomatic individual. So in families with choroideremia, males who have symptoms are the most informative person to test. Usually we have enough clinical information that helps us select the appropriate test to offer them, but also when the results come back, genetic testing is not always as straightforward as a positive or negative. It's not always a yes or no answer. We still have a lot of understanding to learn about variations that exist in human DNA and understanding what variations are actually disease-causing variations and what variations might be just a variant of normal and well-tolerated. It's important to know that the gene testing is being performed in somebody who has symptoms for the genes that you're testing for. And then, of course, once you have a gene diagnosis, you can offer testing to female carriers. It's important to offer testing to those who might be of childbearing age, just so that they can learn about the possibilities. Even if they don't have symptoms, it's important to help them understand that they could have children with this condition, even though they don't have it themselves. And as we've learned, some females can develop symptoms later on in life, and maybe they want to know a little bit more about that as well. And then there's always a debate on whether or not to test individuals pre-symptomatically. But this often comes up when the diagnosis of choroideremia is made. Some people want to know, I have a young child, he doesn't have symptoms yet, but based on my knowledge of this, I'm likely a carrier. I want to know if my son's going to be affected. Maybe they want to know for sure so that they can get him hooked up with the right specialists, make sure that when a treatment does become available, he'll be eligible for it. Often for adult onset genetic diseases, we don't typically recommend genetic testing in minors, primarily because we want to respect their autonomy or their right to make the decision themselves to be tested. But with choroideremia, we know that there's there can be childhood onset of symptoms, and so the lines are a little bit blurred on whether or not to test people pre-symptomatically. And there's no right or wrong answer here, but often it's most up to the family and what they feel is the right decision or how much information they need to know or want to know. And so that's why as we go through the process of genetic testing, it's always important that there's pre-test genetic counseling to help manage expectations of what testing can tell us, but also to help people weigh what's important for me to know and what information may I not want to know, and to help people make informed decisions about whether or not to have testing. And then with that, I'm going to pass it over to Dr. Levin, who's going to talk about how you get testing.
Thanks very much. Let me begin by introducing myself. I'm Alex Levin. I'm the Chief of Ocular Genetics and the Chief of Clinical Genetics at the University of Rochester. Welcome to Rochester. We're glad to have you here. It's a great town. You picked a great weekend. We celebrate June 19th this week, Juneteenth this weekend. So Monday is a holiday, and there's a lot going on in town. The Jazz Festival is here. Those of you with kids must go to the Strong Museum of Play. It is absolutely fabulous. There's a park just around the corner, Powder Mills Park, with a fishery that the kids will love. Lots of things to do here, and we're glad to have you. I'm an ocular geneticist, which translated means I'm a rare disease doctor. And I've been dealing with patients with choroideremia for 30 years. I remember back as a young tyke with Ian McDonald writing a paper together. And, I'm not a very smart guy. I'm kind of dumb, actually. But I see the same things over and over and over again. And that puts me in a position where I can recognize things, right? If my father walked into this room, not one of you would know him. I'd know him in a second because I know what my dad looks like, right? And that's what our clinics are about. It allows us to develop this pattern recognition. How many people in this room had difficulty getting a diagnosis? They went to the doctor and they said, this is what you had. They said, yeah, a lot of hands are going up, right? That's the common pathway. 30% of the patients that come to see me have the wrong diagnosis after seeing 2, 3, 4, 5 physicians. And as Eric said, getting a genetic diagnosis is the ultimate to know what you have. But that starts with getting a clinical diagnosis where someone looks in and says, this is what I think you got. And that leads us to a genetic diagnosis. So how do I get tested? The first thing is phenotype, phenotype, phenotype. Phenotype means a clinical diagnosis where we can look at a patient, take your history, take your family tree, then do diagnostic testing, all those tests you've heard, OCT and fundus, all those pictures and all that, ERGs. Then from all of that information, we can select a gene test. But that first step is really important because that's not something that everyone can do. You have to have the equipment to do it and the familiarity of what test to order. Then you do gene testing after you have an idea of what you're testing for. And what we'd like to do is to narrow the gene hypothesis to get as close as we can to the right gene, in this case, the one gene that causes choroideremia, although there are a couple mimics. We want to get that single gene and test for that problem. We are strongly of the mind to avoid these large free panels. I'm sure some of you have been tested that way. They're available, industry supports them now, where you can get 200 and some genes or more tested in one fell swoop, and it's quote unquote free. Well, it actually isn't free. There's someone paying for it. Just doesn't cost you anything. And there's a reason these quote unquote free tests are being done, to capture data for people to pay large amount of monies to get gene therapy. In the end, that's the company's incentive for paying all this money for testing. But there are other ways to get testing. The problem with the free panel is if I test everybody in this room, everyone who's got choroideremia and everyone who doesn't, everyone who's perfectly normal, who's not related to someone with choroideremia, every single one of us will have abnormalities in retina genes. Because that's just the way of life. We all carry many, many different abnormal disease genes. We don't know what they are until maybe we have a kid that has one, or someone in our family has one. There's no way to know. And when we test large panels of genes, you're going to discover a lot of noise. Some of it is just a variance of normal. Some of them are things we carry. And sussing that out, what's important, can sometimes lead to a misdiagnosis if you're testing stuff that you don't need to know, or it can increase the amount of worry that a person has. If you can test one gene for choroideremia, that's what we're going to do. We'll test just the one gene. And if there's a known gene, if you know the mutation, if someone in your family has choroideremia and you know your gene diagnosis, then if you want to test other family members, you only need to test that single mutation in the gene. It becomes very, very inexpensive just to test for that little one change. You don't even have to look at the whole gene because you don't care what other noise is out there. You only care for that mutation if you're trying to identify carriers and so on. Now, once we send the gene test out, the work doesn't end there. You got to be able to interpret the test. And interpreting the test is quite difficult. With all these free panels, we see a lot of patients getting tested by individuals who are barely ophthalmologists, let alone geneticists. I had a patient come to see me the other day. Parents were really worried that this kid has a life-threatening disease. And that they may be totally wrong. The testing I looked at was interpreted in a way that may be wrong. So it's important that someone who's doing the test knows how to interpret the test. And there's a lot of work. We do a lot of database searching and mining. We think about how this gene abnormality may or may not cause disease, what's it going to do to the protein it makes, so on and so forth, to see if it matches, that it really is, as Eric said, a gene diagnosis, not a gene test. So it takes us about 10 hours for every patient that I spend 1 hour with in clinic to get to a gene diagnosis. And sometimes on the first go round, we may not get the diagnosis. We may have to test again another set of genes, another gene, or test other family members to figure out if we really have the right diagnosis. So it can take months to get to a diagnosis. I have a patient that it took us 13 years to find the genetic diagnosis. We knew what the clinical diagnosis was, but to find her gene abnormality took us that long. It's a lot of work and takes a lot of time. How do you get a test? Well, you go to an ocular geneticist or a medical geneticist who knows what they're doing, who can recognize at first the problem, do the right gene test, and go for there. What about the cost? Well, there's a different way of getting about this. We partner very closely in research and otherwise with the University of Iowa, Dr. Ed Stone, and we have a program that's supported philanthropically. All of my patients get free genetic testing for retinal dystrophies. We do that with philanthropic support rather than industry support, and we're developing gene therapies for multiple diseases. And so there is a pathway to get free testing. There's research pathways that also allow free testing. There are ways to get your testing for free. The thing is, you get what you pay for. And when it's free, you get what you pay for. Free tests are sometimes not the best test. What you want to do is get yourself into the hands of someone who does this as professionally, as a job. I wouldn't want to be delivering babies. It's probably pretty easy to catch a baby. I certainly won't want to be doing brain surgery, but I do ocular genetics because that's what I do, right? And it's really important that patients and their families get themselves in the hands of ocular geneticists. Now, the problem is there's only 70 to 80 ocular geneticists in the world. It's a new specialty in ophthalmology. Medical geneticists, they're more common. They're in most university hospitals have geneticists. The problem is they're less familiar with the eye. Once they know, they still need an eye doctor to tell them what the diagnosis is, then they can help you with testing. So our goal today was to try and get you on the path to a gene diagnosis rather than just a gene test, to get a thoughtful approach to genetic testing so that you can find the answers for you and for your family. So that's all I have as well. We have some time to open it up for questions. If anyone has any questions, go for it. Questions? What's that? One behind the column. There you are. Good.
Yes. My mother carried the gene. My brother's got choroideremia. My other brother, his eyes are fine. I was diagnosed with Coates disease. So I'm only blind in one eye. Have you ever heard of Coates disease?
Yes. So Coates disease is another rare disorder.
Yep.
It's a disorder of the blood vessels of the retina, whereas choroideremia is a disease of the retina and the choroid itself. And Coates disease is a rare disorder. It can occur. Usually it occurs in kids in the second decade of life.
I was told I should have been blind when I was 7, and I didn't get blind until
There's
I was
an
like
adult
40.
form of the disease that occurs late in life as well. Not late, I didn't mean it that way, but it occurs as an adult in one arm, in one eye, and it's unrelated to choroideremia. Some of the retinal dystrophies that we see in the world can have what we call a Coates-like response that kind of looks like Coates. But if your retina is otherwise normal and you just have Coates disease in one eye, you probably had some laser treatment or something like that, it's unrelated to choroideremia. Now you might say, how come two rare diseases happen in a family,
that's
right?
what I was, you know.
Well, when your card gets pulled from the deck, it doesn't guarantee that someone reshuffles, right? You can get your card pulled twice. And that does happen. And we see families with more than one genetic disease all the time. It's rare, but it can happen.
Okay, thank you.
My pleasure.
Thank you very much.
In the back, all the way in the back. Yes, with your hand up, last row.
Hello, can you hear me? Okay, good. Thank you so much for your talk. It's very informative. I'm a female carrier with a brother who has choroideremia, and right now we're under the care of a adult ophthalmologist at UCLA, a retinal specialist, and he has a medical geneticist on his staff. In thinking about testing my own children, do you recommend that I seek out a pediatric ophthalmologist that specialize in retina, and ocular geneticists, sort of like thinking forward for the next generation? Is a ophthalmologist and adult specialty appropriate, or should we be thinking about someone with a more specific specialty?
Great question. Janina, why don't you take that one? The microphone is on in front of you. It says leave microphone on, and it's off.
So it's
go.
working now. Well, I guess this kind of brings up the question of, are we pre-symptomatically testing individuals and whether or not you want to do that. It also comes down to whether you have sons or daughters. For females, usually, even if they develop symptoms, it's not typical to develop them until adulthood. And so they're probably okay until they approach adulthood, and then they can kind of meet with either a physician or a genetic counselor to talk about the pros and cons of testing and make the decision for themselves. For young boys, again, it's hard because it can, if it was inherited, they can have an onset in childhood, and some families just want to kind of put all their ducks in a row and make sure that they're staying on top of the research advancements and treatments. Other families might feel that, let's say I have two sons, one test negative, one test positive. Well, what do I do with that information? I was kind of hoping for relief, and now I know that one son might be affected someday soon. So I would encourage a session with a genetic counselor to kind of weigh all the pros and cons before doing any exams or testing.
I agree 100%. It's important to think about testing before you go and do it. And every single patient who has genetic testing should see a genetic counselor before testing to get that counseling, because there are pros and cons. Some genetic testing leads to surprising things, like you find out your daddy's not your daddy. I'm not suggesting that in your case. But you need to know those risks that you're taking and understand them before you go forward, and ask what you're going to do with that information once you have it, especially until the disease is treatable. When it's treatable, then it becomes a different scenario. I saw another hand. Yep. Go ahead. Yes.
Yes, sir. Again, thank you so much for
Sure.
all the information. It's it's great. Do you do testing? Is it like a cheek swab, or do you do blood work?
So there are two ways to do, well, there's many ways to do genetics, but the two most common are blood test or a swab of the cheek. We always prefer blood. It's more robust. You get better sample. It's more likely to be testable. They both show the same genes. In general, your cheek is the same as the blood. The cheek is easier, less invasive, so on and so forth. If we can get blood, we'll do blood. But sometimes a kid doesn't want their blood drawn, or they're doing it at home. There's different reasons to choose one or the other, and that would depend on your personal situation and where you're sending it, so on and so forth. There's no other advantage. The worst thing could happen is you do a cheek swab, you have to repeat the cheek swab. You won't get an inaccurate result. Go ahead.
Hi there, thank you. 12 years ago, I started exhibiting symptoms and found out that it was likely choroideremia. So, and two of my sons, one son has it, one son does not. And we decided to have my blood tested rather than our son's because he was 15 and we just didn't want, for insurance purposes, we preferred mine. So they sent my blood in, and I believe it was University of Iowa, and they said that it was too difficult to sequence my blood because of the 2X chromosomes. And so they did test my son, and he does have choroideremia. I'm just wondering if tests have changed, if there was a reason for it, and with some of the research that's going on for female carriers, does it make sense for me to try and get tested again?
Why don't you take that one, Gina? We'll play tag.
Sometimes it might be the nature of the mutation or the variant that's affecting the gene that might be difficult to sequence in females as opposed to the males who only have the one copy. If they can find it there, they know that it's there. But sometimes it can help to just check in with the person who had done testing previously just to see if there's updates or if they've improved their methodology in testing to see if maybe it's possible to confirm it on your sample. But usually if they were able to find it in a family member and you have symptoms consistent with it, they can conclude that you likely probably carry it.
Another way to look at it is we always prefer to test the person with the disease first because we know that disease, we recognize it, we see it, and we know we're right when we get it right. And then we would test the female carriers to find out if they have just that mutation. Rarely do we do it in reverse.
Have you guys give them a nice round of applause. Thank you.
Thanks very much. Thank you.